Hi everyone. This is the last session of endocrine physiology. This time, we'll talk about the biological effects of insulin. Here are the learning objectives. When you have completed this session, you will be able to describe the biological effects of insulin, predict the consequences caused by abnormal insulin secretion. As usual, let's start with a case. Lily, a 10-year-old girl, presents with weight loss, fatigue, intense thirst and excessive drinking, a huge appetite, and passing lots of urine. Other findings include glucosuria and a markedly elevated fasting blood sugar. She is diagnosed with type 1 diabetes mellitus and is started on insulin therapy. What are the underlying mechanisms for the patient's clinical manifestations? You will find all the answers when we finish our discussion today. Insulin is synthesized and secreted by the beta cells of islets of Langerhans in the pancreas. Its main effect is to lower blood glucose levels, but it also influences protein and fat metabolism. Circulating insulin brings down blood glucose in 3 ways. It enhances membrane transport of glucose and other simple sugars into most body cells, especially muscle and fat cells. Insulin inhibits the breakdown of glycogen to glucose and the conversion of amino acids or fats to glucose. These inhibitory effects counteract any metabolic activity that would increase plasma glucose. Elevated blood glucose is the chief factor that stimulates pancreatic beta cells to secrete insulin. Other stimuli include rising blood levels of amino acids and fatty acids and acetylcholine released by parasympathetic nerve fibers. As body cells take up glucose and other nutrients, blood levels of these substances drop. Insulin secretion is suppressed. Other hormones also influence insulin release. Hyperglycemic hormones like glucagon, epinephrine, growth hormone, thyroxine or glucocorticoids elevate blood glucose level, thus indirectly stimulates insulin release. Somatostatin and sympathetic nervous system activation inhibit insulin secretion. As you can see, blood glucose levels represent a balance of humoral, neural, and hormonal influences. Insulin is the major hypoglycemic factor that counterbalances the many hyperglycemic hormones. The hypoglycemic action of insulin is the result of coordinated responses that simultaneously stimulate glucose oxidation and inhibit gluconeogenesis. First, insulin increases glucose transport into target cells, such as muscle and adipose tissues, by directing the insertion of glucose transporters into the cell membranes. As glucose enters the cells, blood glucose concentration decreases. Second, insulin promotes the formation of glycogen from glucose in the liver and muscle and simultaneously inhibits glycogenolysis. Third, insulin inhibits gluconeogenesis by increasing the production of fructose 2,6-bisphosphate. The overall effect of insulin on fat metabolism is to inhibit the mobilization and oxidation of fatty acids, and concurrently to increase the storage of fatty acids. As a result, insulin decreases the circulating levels of fatty acids and keto acids. In adipose tissue, insulin stimulates fat deposition and inhibits fat breakdown. At the same time, insulin inhibits keto acid formation in the liver. Reduced fatty acid degradation means that less acetyl coenzyme A substrate will be available for the formation of keto acids. Insulin has an anabolic impact on protein metabolism. Insulin increases amino acid and protein uptake by tissues, thereby decreasing blood levels of amino acids. After amino acids enter target cells, for example the muscle, insulin then facilitates protein synthesis and inhibits their degradation. In addition to major actions on carbohydrate, fat, and protein metabolism, insulin has several additional roles. Insulin promotes cellular potassium uptake by increasing the activity of sodium-potassium ATPase. This action of insulin can be viewed as a protection against hyperkalemia. Insulin ensures that dietary potassium will be carried into the cells with glucose and other nutrients. The major disorder involving insulin is diabetes mellitus. In type 1 diabetes mellitus, there is inadequate or no insulin secretion due to loss of functioning pancreatic beta cells. In type 2, we have insulin resistance of target tissues. Type 1 diabetes mellitus is characterized by the following changes: increased blood glucose concentration from decreased uptake of glucose into cells, decreased glucose utilization, and increased gluconeogenesis, elevated blood fatty acid and keto acid concentrations from increased lipolysis and conversion of fatty acids to keto acids, but decreased utilization of keto acids by tissues, and raised amino acids concentration from increased breakdown of protein to amino acids. There also is the loss of lean body mass, that is to say, a catabolic state, and the loss of adipose tissue. The high levels of keto acids cause a form of metabolic acidosis called diabetic ketoacidosis, DKA. The increased blood glucose concentration results in the filtered load of glucose exceeding the capacity or threshold of the renal proximal tubular reabsorption. The non-reabsorbed glucose then acts as an osmotic solute in the urine, producing an osmotic diuresis. This polyuria will make the patient drink lots of fluid to prevent dehydration. If uncompensated, the polyuria will reduce extracellular fluid volume, leading to hypotension. Insulin replacement therapy is used to treat type 1 diabetes mellitus. Non-insulin dependent diabetes mellitus, or type 2 diabetes mellitus, is often associated with obesity. Type 2 diabetes mellitus is caused by downregulation of insulin receptors in target tissues and insulin resistance. Although insulin is secreted normally by the beta cells, it cannot activate its receptors in muscle, liver, and adipose tissue. Thus, insulin is unable to produce its usual metabolic effects. Typically, blood glucose is elevated in both fasting and postprandial after eating states. Treatment of type 2 diabetes mellitus include caloric restriction and weight reduction, medications that stimulate pancreatic insulin secretion or upregulate insulin receptors in target tissues. Now let's come back to the story of Lily. She has type 1 diabetes mellitus. All the signs and symptoms are caused by insufficient insulin secretion. In summary, insulin promotes the transport of glucose from the blood into cells by increasing the permeability of cell membranes to glucose. Insulin promotes storage of glucose as glycogen, storage of fatty acids in adipose tissues, and storage of amino acids as protein. Deficiency of insulin results in type 1 diabetes mellitus. Insulin resistance of target tissues cause type 2 diabetes mellitus. Insulin is a vital hormone. We cannot survive for very long without it. That's all for today. Thank you very much for joining us.